In this next session, we are going to be talking about Parkinson's. And I think this is a really great topic for us to be talking about because in the NHS, as such a complex disease area, there are so many ways that it touches upon the NHS resources, it affects people's lives, and I think we often spend so much time talking about the biggest order of magnitude disease areas, but we've got to make sure that in those areas, such as areas like Parkinson, that we're thinking about the real impact that technology can make on those. So I'd like to welcome Andrew Mullen and hand over.
Thank you, Liam. There's part of me wishes that I'd done this talk before the last panel talk where I heard the advice not to turn up and tell anyone we've got a solution, because guess what? So yeah, Andrew Mullen, CEO of Charco Neurotech, and we're on a mission to bring back smiles to people with Parkinson's. And where that came from was an encounter that our founder had with a person with Parkinson's who said, people think I'm angry, but I'm not. Parkinson's has taken away my ability to smile. So we fast forward 5 years, and here we are, and I'm stood here wanting to tell you about a viable, cost-effective solution for evaluating the motor symptoms of Parkinson's. And here's where we come to the solution part. So more than 150,000 people live with Parkinson's in the UK at this point in time, and it's one of the world's fastest growing neurodegenerative diseases. Now, I think we all associate tremor and cognitive impairment with Parkinson's, but actually, it's the symptoms relating to balance and movement that are far more impactful to the patient and to the NHS. So things like rigidity, slowness, stiffness impair a person's ability to mobilize, to take care of themselves. And freeze of gait, which is one of the most problematic issues with Parkinson's, is responsible for way too many falls. Now, when we look at the deck at the left-hand side there, you may be thinking, well, there's medication. Isn't that good enough? And sadly, the answer is no, because many people with Parkinson's remain symptomatic despite pharmacological intervention. They experience poor tolerability. The side effects profile is really, really problematic. And actually, medication doesn't do a very good job of tackling freeze of gait. In a lot of cases, it exacerbates postural stability, so leads to the very falls we're trying to prevent. So I'll read the numbers out. 40 to 70% of people with Parkinson's will fall each year, a third of those falling repeatedly. 65% will result in injury, and about a third of those resulting in fractures, which again, you guys need to deal with. And the cost to the NHS is over £212 million per year. So what's the solution that we're kind of waving in front of you? We have the Q1 Plus device. So this is a non-invasive, safe and convenient device. And it combines two principles of vibrotactile stimulation and cueing. It's the first medical device to gain regulatory clearance, combining both of those modalities. So if you want more detail on the science, please come down and see us on F11. But at a very high level, focused vibrotactile stimulation has been around, it's been known about for a long time. So in the 19th century, Professor Charco identified it as a potential potential solution to movement disorders and developed the famous vibrating chair. Fast forward 200 years, and people have experimented with devices that localize upper and lower limb, through to whole body vibration, but the results have been very unrepeatable and unconvincing. At Charco, our research has shown that wearing a device with specific frequencies on the sternum exploits the bony structure in terms of providing amplification around the rib cage, around the sternum, but it also exploits the peripheral nerve pathways so that we're providing a means of neuromodulation. Combined with that, cueing. So cueing is a well-established, well-understood therapy for Parkinson's. So we're literally talking about providing a rhythm to keep people moving to move to. And that could be audible, it could be visual, lights flashing. And in many cases, clinicians will ask a patient to count in their head when they feel an episode of freeze. Come on, just start counting. What we do at Charcot is we incorporate that into the vibrating function, so it's far more discreet and far more reliable. I have a couple of case studies that I want to talk about, but at the start of this one, for those that are not familiar, MDS UPDRS, as it says there, it's a unified Parkinson's disease rating scale, and it's a pretty much universally accepted means of assessing the severity of symptoms in Parkinson's. Broadly speaking, a big number is bad, a low number is good. So in this study, we looked at a gentleman, 75 years of age, 15 years history of Parkinson's, with deteriorating motor function. So he was falling regularly and pretty much relied on his wife and his carers to be able to mobilize. We took baseline assessments, which are shown in the big dark blue bars there, and then we repeated the assessments after 14 weeks. And as you can see there, as we've highlighted in red, we saw some pretty dramatic results, some pretty dramatic improvements in those, the ability to mobilize. But more excitingly for us, whereas the individual was experiencing a typical 18 falls over 14 weeks, with the device, this number was brought down to 3. Now, not all of those 18 falls would have required hospital admission, but statistically, we're putting the guy in a much better position by reducing it. This was another case study. So in this case, the patient wore an independent monitoring device, which provided continuous monitoring of mobility, looking at movement, freeze of gait, and general mobilization. And what we found is over a 5-day window without Q1, this person experienced 134 freezes. That's 134 potential falls. With the Q1 device, over a 5-day period, just the same, that was reduced to 53. So from 26, almost 27 incidents a day, down to 10, 11. Again, massive, massive reduction in that falls risk. But over the same study, we were able to look at medication on and off state. And for those that are not aware, Parkinson's medication has a well-known phenomena of an on state, so the period of time for which the medication is effective. And what we saw is without Q1, that on state was around 13 hours a day. With the Q1, that was extended to 20 hours, so pretty much the entire waking hours of the individual. And why that's important is it gives us indication that we can actually extend the period of time on a particular dose of medication and slow down that escalation through the regime, so delaying the progression, obviously reduces the number of interventions, keeps some costs down, but it also significantly reduces the risk of side effects for the individual. In this study, we took real-world data from 117 users, and again, using UPDRS. At baseline, you see the assessments in the green box plot, and then an average of 4 weeks later, we repeated the assessment, as shown in the orange, and again, we saw a dramatic improvement in motor function. I think an important point here is under the UPDRS, 3.25 points reduction is classed as clinically significant. But on average, the participants demonstrated more than 7 points improvement. And then finally in the studies, this is our most recent study done by Queen Mary University London. It's currently under peer review for journal publication. And basically, we look at 10 patients, people with Parkinson's. We do a baseline assessment, and then every 3 weeks, repeat that assessment. And you can see there, after the first assessment, we've seen a significant reduction in UPDRS scores. But what's more encouraging is over the period of time the person uses that device, they're mobilizing more, and those improvements continue for the duration of the study. At the same time, we looked at functional gait. Functional gait assessment is a 10-item test that looks at various tests of postural stability during walking activities, walking up an incline, walking backwards, turning, stopping, stooping. On this scale, 0 is a significant impairment, and 3 is pretty much normal ambulation. And what you can see there is pretty much all of the patients started with significantly impaired gait, but by the end of the trial, pretty much all of them were very close to normal ambulation. So reflecting back on the previous panel, why are we here? Well, we feel that we add real value, or the potential to add value, to the ICBs. Everything that we do feels to be aligned with NHS priorities and in line with the long-term plan. So as I've tried to articulate, we're managing chronic conditions, we're helping people to age well, we're looking at preventing falls, and in doing that, we reduce the burden on your acute services, so that ambulance no longer has the person with Parkinson's who's fallen, it's gone to somebody else. And in terms of cost-effective innovation, the device is a few £100 versus the cost of all of those issues relating to falls, relating to reduced mobility, care in the community. But in addition to, just on that note, in addition to the acute services, the secondary care, so people that are having home visits, we have enough data to support our assertion that we can reduce the number of care visits that are needed afterwards because people are mobilizing themselves. So I stand here in amongst this forum rather than trying to pitch to investors or tell anyone how good our digital innovation is, because our call to action here is to work with the ICBs. Q1 Plus is available on the National Health Supply Chain Framework. The adoption, we're not looking to change the way you run your service, so it would be part of the normal assessment process as it runs for Parkinson's. We have a dedicated community who are there to, community support team, sorry, who are there to support both patients and clinicians in deployment and in operating the device. We have a wealth of data that we continue to develop, and we can make that available to support your business cases. Alongside the health economic and the budget impact models, we've got a lot of detail there, and we want to work with you guys to understand what that really means on a trust level, and what the savings really are, because to us that data is just so compelling. So there it is. Speak to us on F11. We've got a stand down there. The call to arms here is, please, we want the opportunity to work with you. We'll provide devices, we'll provide support in exchange for that ability to prove the cost model, and look at ways that we can get it implemented throughout your trusts and your boards. Thank you.